Okay, well, I don't want to waste too much time here, but I see people are joining, which is great. So good morning or good afternoon, depending on where you are in the country. My name is Bianca Frogner. I'm the webinar chair for the Award Network monthly webinar series. I'm also part of the leadership team of the Award Network, and I'm also a professor and director of the Center for Health Workforce Studies, which is housed at the University of Washington in Seattle. I'm really excited that we're going to have Jeffrey Boone today speak with us. He's a postdoctoral fellow at Vanderbilt University, and we'll have a moment to introduce him a little bit later. But as always, we'd love to hear from you about webinar ideas that you have, because this series really is meant to help you all learn more about anything related to the long-term care workforce, the dementia workforce, how we can provide better care for folks with people living with dementia. So please share with us your ideas using that QR code below. Just a few housekeeping items. We have our next month's webinar coming up on October 1st. It's going to be on an age-friendly approach to dementia care. And as always, we have all of our webinars, prior webinars recorded, and they are online. So you can also find that on our website. We are lining up our next series of webinars. So keep an eye on our website as well as our newsletter to see when those webinars are coming. Hopefully, you're also getting the regular reminders and announcements about our webinars. And if you are not, please sign up online via our website to get those announcements so you don't miss any. Save the date. I know many of you may be going to the Gerontological Society of America's annual scientific meeting. We will be having our annual meeting of the Award Network on Thursday, November 13th. So please save the date. You should soon see some information of more detail, but we have a time and a location as indicated here on the slide. If you haven't heard, the National Dementia Workforce Studies has their first wave of data available, and it's free. It's public. It's public use, so please take advantage of that. We do think that many of you in our network would find this data useful for your own work, so please go check that out. You can also get access to the restricted use files through the NIA linkage portal. I want to thank our webinar committee members today for their great work to get this whole series together. It's with this wonderful team that we can bring to you a broad array of speakers and topics. If you have any interest in joining the webinar committee, we always welcome folks who may want to volunteer. Jin will be emceeing our event today, and I'll turn it over to her briefly soon. But I do want to also thank our leadership committee of the Award Network for all that they do to make this whole network possible. And then also I want to acknowledge National Institute on Aging, who is the funder behind this series. However, the views expressed in the webinar do not necessarily reflect the official policies of the Department of Health and Human Services or NIA. So with that, I'm going to ask Jin, who's part of our webinar committee, to come online here. She's a professor at Ohio State University. Oh, sorry, the Ohio State University, and she will introduce our speaker today. And we'll have Q&A at the end, so please use the Q&A function to put your questions there. So Jin.
Well, thank you so much, Dr. Frogner. Well, welcome everyone. This is actually very exciting to introduce today's speaker, Dr. Jeffrey Boone. He is a postdoctoral scholar here at The Ohio State University. He came from Vanderbilt, so you saw Vanderbilt name on the slide earlier. I'm very excited to introduce you Dr. Boone, who's a board-certified adult gero acute care nurse practitioner. He earned his BA in philosophy, so we've had many philosophical discussions. He earned his bachelor's degree from Rhodes College, and he's nursing MSN and PhD from Vanderbilt University. And before his research career, he practiced in neuroscience ICU at Vanderbilt University Medical Center. His research focuses on dementia family caregiving with a particular emphasis on pain management. He is also a recipient of the NIH Loan Repayment Program from National Institute of National Institute of Aging this year. So yay. And he was also selected from a very competitive international pool of early career researchers to attend the North American Pain School in Quebec, Canada this summer. Um, in recognition of his leadership and expertise in dementia caregiving and pain, he was elected to the board of directors for the American Society of Pain Management Nursing. And his term will begin this fall in October. He serves on the editorial board of Pain Management Nursing and is an active member of several professional organizations, including International Association of the Study of Pain, the United States Association of the, so in both international and the US Association, the Study of Pain, the GSA. So hopefully you'll see him in October or November at GSA. Beyond his academic and clinical work, Dr. Boone is deeply committed to community outreach, and he's been very actively engaged with our community here in Central Ohio at different memory care centers. And he is also engaging nationwide using virtual platform. And he also contributes to the Alliance of Diversity in Brain Health for the Central Ohio community. So with that, without a further ado, I will turn this over to Dr. Boone. Take it away.
Thank you very much. I appreciate that. And yes, I'm no longer at Vanderbilt, but I did, of course, love Vanderbilt, so go Doors. I'll start sharing my slides and hopefully they share as they're supposed to. Um, and am I presenting the correct slide? Let's see. So this talk is titled Family Caregivers in the Dementia Care Workforce, the Case of Pain Management. I am predominantly initially started as a more of a pain scientist focusing on pain, but realized the issue of pain in people living with dementia, and especially the needs regarding pain in their family caregivers, whether it's assessing and managing pain in the care recipient, or in fact, the pain of the person themselves who is providing the care. Okay, apologies for that. I messed up my dual screens yesterday, and I'm still discovering ways in which I have to recover that circumstance. Um, so I am a postdoc here at the Ohio State University College of Nursing, no longer at Vanderbilt. Um, a lot of information, but all of it is referred to in some way in the slide. So I just wanted maybe a bit of an overshare of any disclosures of funding mechanisms where I get paid from, or where I have leadership roles. But how did I get interested in the issue of family caregiving and pain in people living with dementia? As trained as a nurse and a nurse practitioner. It initially came from clinical observation. I worked in a neuro ICU, and one of the difficult problems that arises is agitation and its etiology in older adults. And I did observe a very experienced nurse practitioner would always assess for pain first. And that started me thinking about the fact that maybe we jump to other things for pain, and especially when we talk about behavioral and psychiatric symptoms of dementia. And in fact, agitation in those circumstances was often pain related. I also enjoyed the care of older adults, both with and without dementia, just in my clinical practice. And then, kind of narrowing down to the question of family caregivers, I had my own family certainly has had, with older adult relatives, has had caregiving needs. And I remember talking to my father about taking care of his father. And he said, I always worried my dad was hurting and I just didn't know it. And that certainly struck a chord with me, the fact that it's a great concern, and certainly we don't want anyone who is in our care to be experiencing pain. But there seemed to be a gap, and it was evident in the literature as well, that family caregivers desired more training, more support, more understanding of pain, and so to begin really investigating down that road. And I have a current study going on, a qualitative study, where I just in the last couple of weeks had a family caregiver say to me, nobody ever talked to me about pain. Nobody ever asked me about pain. And so it made me recognize that there's still ongoing needs and that caregivers do experience that very acutely. So I'm going to focus on three questions today. First of all, who are dementia family caregivers and why do they matter in a workforce discussion? What are some of the issues surrounding pain management by family caregivers of people living with dementia? And what can we do about it? Um, so those will be the three focus for today. But talking about caregivers, it's a broad term. A lot of times we think about the direct care workforce in dementia workforce studies, and I'm certainly tend to think of myself more as a clinical researcher than someone who does health services or workforce questions, but in fact they overlap. And so we use a lot of different terminology. I tend to use the term family caregiver, and that can also be like an unpaid caregivers language you see, informal caregiver. But generally, the term includes relatives or non-relatives who have a broad array of assistance to provide to the person with dementia. They participate in activities of care in the residential setting or at a distance. Um, and so we do have to really, especially when we're trying to identify them for research purposes or for intervention purposes, define what they mean. And certainly that theme will come up again and again in caregiving research because unlike people who know where their paycheck comes from, a lot of individuals in the direct care workforce, family caregivers, oftentimes don't recognize themselves as such. They may say, "Well, no, I'm not a caregiver. I I'm doing what I'm supposed to do as a spouse or as a child." And so it's one of the challenges we have in reaching them for research purposes, but also just measuring this workforce because a lot of people who don't consider themselves to fulfill a really important role, and that I argue is a key component of our dementia care workforce. And so I'm an NPR listener and I enjoy Marketplace. Not that I am a expert on the market or could tell you where to invest your funds, but I always notice when I'm listening that Kai Risdall says, let's do the numbers when he's about to tell us how the market did. So I pulled these from the recently released 2025 Alzheimer's Disease Facts and Figures, just to give us an idea of what the population of family caregivers looks like. More than 11 million Americans are providing unpaid care for someone with Alzheimer's disease or another dementia. And of these, about two-thirds are women, 66% living with the person with dementia. Um, Over half are married or in some kind of long-term partnership with the care recipient. And a really unique portion are about a quarter of the sandwich care generation caregivers. That is, the ones who are caring both for an older generation, a parent or some other older relative, as well as still have caregiving responsibilities, for example, for children in the house. And so, it's once again, it emphasizes to us that when someone becomes a family caregiver, it's not like it's a new job, it's an additional job into their ongoing caregiving responsibilities, as well as anything else that competes for their time and energies. And then there's actually, I didn't include here, but I was at a conference recently and there was an emphasis on youth caregivers, and that is youth who are still providing care, whether in multi-generational households or across households for older adult relatives, but they themselves are still youth. And that is a growing area of attention. Farron Epps is giving it a good deal of attention, especially as part of her Alter Dementia Care Network. Over half are caring for a parent or in-law. About 10 provide care to a spouse, 10%, and many of the spouses do the caregiving alone in the sense that they don't identify other people who are involved in providing the care. From an racial and ethnic standpoint, about two-thirds are recognized as white, 10% Black, 8% Hispanic, 5% Asian American, and 10% other populations. Um, but there are also people living with dementia who actually don't have any caregivers, about 8% of these people, and nearly half of those are living alone. And there's especially we have to be mindful of this because there are certain populations that may be especially vulnerable to this risk of not having a caregiver. One example that's pointed out is people who are sexual or gender minorities may have been victims of stigma and the minoritizing impacts of stigma over time that causes them to be alone, that may result in some estrangement and having a decreased or disjointed social network. And so it becomes difficult as dementia symptoms develop to build a caregiving network for this person. And they may, because most people are receiving care in the community, they may go without care and are certainly at higher risks of adverse effects as the disease progression occurs. And not terribly surprising to me, women do much of dementia family caregiving. About two-thirds of the family caregivers are women, and that proportion is higher here in the United States than it is in some other places, such as Japan and Europe. If there's a large amount, over 40 hours of care a week, which is to say, taking on another full-time job, 70% of those family caregivers are women. And women are more likely 2.5 times to be living with the care recipient when men are, at least part and due to the distribution of diagnoses of dementia or women's longevity compared to men. Um, but these women then, as a result of this disproportionate burden of the family caregiving responsibility, are at risk for higher levels of burden, mood disturbance and depression, or impaired health. The impaired health is getting a lot of attention among family caregivers in the sense that physical activity is decreased, even though it could confer great benefits. And also deferred health care for themselves in preference of attending to the needs of the care recipient. And so we see worse health outcomes for people who are having these intensive dementia family caregiver experiences. This is an older paper, and so it probably bears repeating at this point, but I've always found it very interesting by Jennifer Reckery. She looked at the 2015 National Health and Aging Trends Study that only of all the community dwelling people with dementia, only 25% are receiving paid care. And of those, 10.8% receive more than 20 hours. So again, all those remaining hours are somehow filled in by members of the family caregiving network. So paid caregiving only accounts for about half of care received. And there are people who are at higher odds of receiving paid care are men, those who are unmarried, those who are also able to receive Medicaid services, paid services, and those who actually already have more intensive needs in terms of their activities or instrumental activities of daily living. Certainly, I think there's a number of cohort effects that could have changed this. Obviously, our favorite one, the COVID pandemic, may have had a significant impact on um, these numbers. And so I think, and the fact that we've had a decade of ballooning numbers of people living with dementia while we're still trying to continue to increase access and to services and sufficient workforce to meet the needs of this growing population. So this is probably has had enough information that it's time to repeat this. And then looking at the last years of life, also family caregivers of people living with dementia provide 3 times more total hours of care than than those who are caregiving for someone without dementia. So again, a reminder of the extreme impact compared to other conditions that dementia family caregivers experience. Within the United States, this represents about 19.2 billion hours of care, valued at $413 billion. I'm not an economist, but that sure sounds like a lot to me. And family caregivers bear a significant cost of this. The lifetime cost of caring for someone with dementia is high, and it's borne primarily by the family caregivers in terms of a lot of factors, whether it's actual medical costs, um, or missed wages or anything like that. Um, The financial toxicity is a variable that is the negative financial effects of caregiving or a medical condition experienced by at least over half of the family caregivers of people living with dementia, seen more in Black than white caregivers. Older caregivers tend to be shielded somewhat from that financial toxicity effect, especially if they are out of the workforce otherwise. uh, such as if they are retired or as older caregivers going to have potentially a shorter exposure to the caregiving experience. Um, and there's disparities. The replacement cost of informal care is disparate based on race and ethnicity. Hispanic families have a higher replacement costs compared to Black compared to white families. And so the burden again has a racial and ethnic disproportionality to it. And we're expecting to see growth in that replacement cost. National study of caregiving waves have been analyzed and estimate, and this is all caregiving, not just dementia care. Um, by 2060, a very significant, what is that, almost threefold um, increase in the replacement cost from unpaid family care, over half of it being related to dementia family caregiving. This is due to foregone earnings, productivity loss, and again, also expecting to see racially and ethnically minoritized groups to bear a disproportionate cost in this regard. And even with paid caregiving in the home, this is a quote from another one of Jennifer Reckery's studies where family caregivers say, I am the home care agency. Even with paid support, family caregivers have significant demands placed upon them, whether it's day-to-day monitoring of the services for their safety, for their quality, training and coordinating caregivers, especially if you see turnover in your home care workforce as well as building relationships with these paid caregivers that tend to result in more longevity and the perception of better care experience. And so, even when there's paid caregiving, family caregivers are very actively involved with the dementia care workforce. There are benefits, of course, to having paid care. If you have full-time paid care, there's a 70% reduced odds of activity restrictions due to caregiving and reduced caregiver strain. So certainly, while I certainly recognize the significant impact of family caregiving, the paid caregiving workforce needs to be there for these people as well. So what are about the caregiving implications of pain in people living with dementia? The next three slides are quotes from Lee Pugh's study, where she talked to healthcare providers, family caregivers, and people living with dementia. And from a healthcare provider, they said the ability to communicate reliably is a big challenge. So, in those with more advanced stages of dementia, they're losing their ability to communicate and cannot necessarily tell us where the pain is, what type of pain it is, or how severe it is. They may be telling us something that's not reliable. And that is from the healthcare provider who is ostensibly the person with the most expertise to address these issues. Family caregiver says, I don't know if it's genuine pain or if they're uncomfortable with something, but can't describe it. It's hard. Sometimes you would say, ouch, making a noise or grimacing, but can't verbalize it, so it's really hard to know. Again, that unknowing, that uncertainty of information. But then also a person living with dementia, this one was very interesting to me. The inability to understand the chronic nature of my back pain made me so frustrated with the medical professions. I had one GP tell me that people with dementia don't experience pain. And whenever I showed that last sentence there, people are oftentimes very surprised. And yet I have actually heard that in the clinical and the research environment. It's not a large belief at this point, but I have still heard it pop up before. And there are absolutely alterations that I can talk about in the way that pain is processed. And we're studying right now here in our lab changes in modulation of pain. But people with dementia absolutely do experience pain, but there has been a belief that existed out there that they do not. So certainly an unmet need. Um, some differences, what you'll notice, these are all old studies that I referred to, and that's because we've actually spent a fair bit of time characterizing the ways that these processing mechanisms are different. Um, Aspects of memory impact both reporting as well as remembering intermittent pain states to address them. The qualitative experience still exists, but it is changed, even though we have preservation of activity in the sensory cortical areas. And we also observe changes in verbal and behavior related to pain. One of the most interesting ones that comes up is alterations in facial responses. They're usually increased, likely related to, decreased inhibition in Alzheimer's disease. That's a well-categorized area of research. And it didn't take Miriam Coons, who did this study here. It only took one of my family caregivers that I interviewed recently who said, it's in her face. When I asked about how they assess pain, they said it's in her face. And I thought, yes, it is. You did what the neuroscientists did, a lot of very difficult research to tell us. And in fact, that is one of the important characteristics of pain assessment in people living with dementia, is that we have these increased facial responses to not just stimuli. And unfortunately, we get some behavioral effects that can be very problematic. There are a lot of neuropsychiatric behaviors associated with dementia. Of course, not all the time are they related to pain, but certainly we want to consider pain as part of it. We see changes in behavior, aggression, anxiety, changes in appetite or eating, disinhibition, irritability, nighttime behavior changes. And these are the ones that are problematic. There are other ones, such as being withdrawn and everything, that aren't behavioral in the disturbances that necessarily bother people, but there's still a change and a problem. But there's a higher severity of these behaviors in people who are experiencing pain, up to a third percent higher. And then also this results in a higher level of distress caused to caregivers, associated with the behaviors that could be mitigated by better pain management. The common causes of pain-related diagnoses in people living with dementia are much like other older adults, but they're a lot more difficult to detect as we look for an underlying cause of pain, when someone cannot as easily report. And so certainly the family caregiver kind of becomes the primary care as well, kind of starting to dig in on things and determine when they need to go in for further evaluation, what they can act on at home. But these are all the same kind of causes of pain in other older adults, but detecting them becomes a little more difficult in dementia. And in terms of pain measurement and detection, it's difficult to measure. We have a very hard time measuring pain, period, throughout pain research, but especially in dementia. We often rely just on observational tools to detect it. And so we get studies in different settings rating pain prevalence anywhere from 8 to 80% in people living with dementia. But we do know that it tends to get much higher towards the end of life. Again, common in a lot of older adults, not just in dementia. But one of the big challenges in pain research, of course, is measurement always. Our key message is that people do experience pain. People with dementia process the pain differently, and how it's perceived and processed doesn't actually change the fact that there is a pain experience. The sensation is still there, and people still report both pain intensity and unpleasantness in response to noxious stimuli. And that unpleasantness gets to the emotional or affective component of pain. And so we know that people also experience the distress with dementia differently, but still very much so, and maybe in different proportions to reported pain intensity. One reason that family caregivers are so important is that it's actually the value of knowing the person that matters. Caregivers who know the person well can often detect pain earlier. Again, that's also when we get to the dementia, the direct care workforce, paid caregivers who have this long history. So again, importance of these relationships, whether in the home care environment or the long-term care setting. But family caregivers are a wealth of information related to pain-related conditions, previous patterns of behavior, and also understanding attitudes and beliefs. In fact, family caregivers, despite reporting a great deal of difficulty in pain assessment, have also expressed a lot of desire to improve in assessment and management. And so that's a lot of what the questions that I ask and look at are about. And so what can we do about family caregiver needs for pain management? Well, we have some guidelines. We have behavioral pain assessment tools, and they're mostly designed with healthcare staff in mind. I'm a member of the American Society of Pain Management Nursing, so that's my bias here. But we have a statement designed for the patient unable to self-report, think it's very useful. It's very informative. It is really targeted at nurses and other healthcare providers. In fact, one of the recommendations is seeking information from the family caregivers. We have a number of behavioral observation assessment tools available to us as healthcare providers. One of the challenges is that they have not been validated or used very much. That's starting to change in family caregivers. That research is ongoing. And it's difficult to give some interpretation of what these things mean. Our behavioral pain assessment tools combine a set of behaviors that can be observed and rated. They do have very clear instructions. They are not simple, just pull out the tool and check your boxes. They do require instructions and understanding definitions, and it's one of the challenges in translating them from the healthcare environment into the family caregiving environment. The Pain AD is the one you see most commonly. I do know off the top of my head it exists in Epic, so it may be the one that you encounter when you're doing any work with the electronic medical records or something like that. The PACS 2 developed in Canada is a behavioral list. The MOBID 2 from Europe is where it was initially developed. It is more about movement evoked pain, trying to detect pain based on responses to movement. Um, I'll s- I can't remember if I have a slide now about this, but I will say briefly. One of the challenges of the pain AD is that it gives you a 0 to 10 score. And we think that sounds wonderful because if you've been a nurse or you've ever been in a healthcare setting, you go in and you get asked to tell them about your pain. And if you say that you have pain, they initially start doing a multi-dimensional assessment. And one of the things they assess is intensity, and you always get asked to rate it on a 0 to 10 score. Unfortunately, this scale also gives you a 0 to 10 score, so people tend to interpret that result as a measure of intensity, but we can't say for certain that that is intensity. We tend to use it more as a observation and screening tool than a dimensional tool of pain, trying to measure one of the dimensions, which is intensity. And so that's a challenge that gets presented. And especially if you want to translate it to family caregivers who will adapt from very familiar circumstances, like their experience of going to the hospital or the doctor themselves and being asked to rate their pain in that manner. Even more complex are meta tools that actually combine aspects of many different tools, trying to get at the strengths of all of them. The PAC 15 and PIMD are two that have been developed and have varying levels of support right now. They're ongoing. But again, that really adds complexity into something that is needed um, to be a little less difficult for family caregivers. So again, another challenge that we face is some of our best tools are starting to be validated for family caregivers, but still need some more work. Also looking at both assessment and intervention, these are just examples of interventions that are being developed and studied. Oh, I'm misspelling. I'm so sad. Oh, I apologize for that. But I I'm not particularly endorsing any one or any of them because they are in progress right now. Pain identification communication toolkit is being done right now. It is 6 modules over 4 weekly telephone sessions with a trained interventionist where family caregivers are taught about observational pain assessment and also about effective communication, particularly with healthcare providers. And it provides different skill building activities and opportunities. Again, getting to that component of self-efficacy theory as at least part of the framework there. Um, PaySap is an app that starts out by kind of assessing where the challenges the caregivers experiencing are. It's app-based. They then target different strategies to the needs of the learner. They also have a library of resources and a way to have a digital pain diary, which is something that I often recommend to family caregivers because it can be useful for better healthcare provider communication about how the individualized pain care plan is working out for the family caregiver and the care recipient, and things can be modified, trends can be observed, and you should be able to actually determine somewhat of the pain behaviors that are especially unique to the individual. Because again, while we know a number of behaviors across the board, every individual is unique. Again, one of the challenges when I work with family caregivers is they would love a cookbook. They would love just a if the person does this, then you do this. And unfortunately, it's never really that simple. Um, and again, it's that individual relationship and knowing the person that helps inform that. And there's also Pain Check. I know this is the one I know the least about. But I only provide an example because it is a little different. It uses AI assisted technology for facial expression analysis. And again, earlier I talked about the fact that facial expressions are a key aspect of observational pain assessment in people living with dementia. And there is the facial action coding system that can encode different muscle movements across the face from video imaging. And so it takes advantage of that to then put those pieces into other inputs from the caregiver who is trying to rate an observational pain score. There are some gaps still in validation. There are also very little study of this with family caregivers. This was really designed for long-term care, but I have heard people talking about trying to implement it into the family caregiving space. And each of these has components that I've certainly thought about at one point or another in terms of thinking about future supports for family caregivers. And so I think they're all three things to follow. But Pain Check does have still some validation issues that are being addressed. Um, but I don't favor one or the other. I just present them as examples. Um, and then getting to some of the things that I've done, I've actually looked at the role of caregiving self-efficacy in family caregivers related to pain assessment. As a review, kind of up top, the components of self-efficacy back to Bandura. It consists of performance accomplishment, vicarious learning, verbal encouragement, as well as the emotional or physiological state that the learner is experiencing. And what I found was is that there are two types of caregiving self-efficacy that seem to be associated with implementation of more components of pain assessment in dementia family caregivers, and that is related to their ability to obtain respite and their self-efficacy to respond to disruptive patient behaviors. And the disruptive patient behaviors probably makes the most sense, of course, because as noted a few slides ago, a lot of those can be related to pain. And so you can imagine that someone who is adequately assessing pain is more likely to feel more confident in their ability to manage these disruptive behaviors. Um, Caregiving self-efficacy is important, and in fact, it's what I think that is one of the key frameworks to build interventions on. But what else? One is the loneliest number, they say, but there is a significant risk of loneliness in dementia. But what I found in a previous study was that if I asked family caregivers, do you use information from other people when you're making a pain assessment? They tended to say yes, they do. And it was very interesting to me because there was a question I didn't think I was going to get much of an interesting response from. And it was one of the more interesting findings in that study. But I didn't, unfortunately, ask them, well, who is it? What do you do with this information? How does that happen? And so forth. So I did another study, and that's what's going on right now. It's enhancing family caregiver networks for pain assessment and dementia. This is a qualitative study where I'm interviewing current and former family caregivers of people living with dementia. I'm asking them all about their pain assessment. And of course, question was initially about pain assessment, but we end up talking about pain management and also their needs for training, how they would like to learn about managing pain. And so I'm getting a whole lot of information. Um, Caregivers, one of the challenges that's emerging in these interviews don't often readily identify their network. They start out the saying, yeah, it's really just me. It was hard work. And they have this experience of it being hard work. They feel very isolated. And so, but then if you start to ask them questions about, well, who do you rely on for this? Who's involved in this? And it turns out there's only uh, a very small handful in my sample who actually are pretty isolated caregivers. It turns out that then they start describing a caregiving network. And in fact, once I start those probing questions, I usually don't have to ask many questions before I get a lengthy description of who else is involved, who else they talk to for different pieces of information. And when prompted well enough, people will start to spontaneously describe a caregiving network. And so it's interesting to me that that most people didn't recognize that they have a caregiving network, but in fact, when prompted, they will describe it. And so one of the things I want to look at in the future is how can we leverage this to help people identify their caregiving network. I'm interested in it in relation to pain, but certainly it doesn't stop there, and we should definitely expand it to other needs within the caregiving context. Um, that if we do find a way to leverage this to improve symptom management, um, will it also have really good impacts for the caregiver? Not just the fact that the care recipient experiences less pain, but does this move us to a situation where the caregiver has a better experience and outcome as well? So I think there are a number of studies right now where people are looking at characterizing caregiving networks in dementia because we're realizing that this can be a key component of improving this portion of the care workforce. Um, there's also a recommendation for developing resource centers at the regional level to connect people to available services and supports, maybe offering services and training. We have an example here. We're not the only one, but here at the Ohio State College of Nursing, we do have a Golden Buckeye Center for Dementia Caregiving. And we actually don't reach out just to family, but also to anyone who's involved in dementia caregiving. It is sponsored by money from the state. So we have a mission for training, providing resources, and then also it can be an avenue for research as well. But the idea is that these are regional level resources so they can meet local needs. Some policy considerations. Back in 2018, we had the Raise Family Caregiving Act. We got the National Strategy to Support Family Caregivers. We had a great deal of recommendations come in that strategy for education training. There was not a ton about pain, but certainly that can be built into there. And then with the guide model starting to have the dementia care programs as an approach to comprehensive care for dementia, I would like to see how we as clinical pain researchers and people developing interventions can bring that to that model and make it accessible through these comprehensive centers where healthcare provider communication about pain is facilitated by our interventions, as well as bringing education back to family caregivers on how they can assess and manage pain. I think that those settings could be that we could tailor our interventions to use in those settings, and that could be really helpful in the future. Obviously, federal policy, state policy is always changing, but I think this is right now a really great place that we could target our energy. So at the end, what evidence are we still missing as clinical researchers to develop the best resources and supports? That's what I'm always looking at. How can we bring the crucial dementia family caregivers into the workforce conversation? As I was digging in preparing for this, I was thinking it was really inappropriate for me to do a workforce presentation. But then I realized that our family caregivers are a key part of sustaining our dementia workforce. And so it made much more sense to me. And of course, family caregivers will only become more important as the growing demand for dementia care continues to grow. So we want to find ways as clinical researchers to kind of break down those silos between different areas of research to bring our evidence into policy frameworks, existing systems and programs that are already working for many purposes, as well as into workforce initiatives that can help meet the needs of dementia family caregivers. And I'll stop there and I'll stop sharing um, and open it up for any discussion. Um, Thank you so much.
Thank you so much for that presentation. I'm gonna see if there are any questions from the audience or from our leadership. If nobody, I actually do have two quick questions. I don't know if I missed it, but what's the prevalence of chronic pain in patients with dementia? Maybe I missed that, but is it higher than?
So I kind of in trying to like cram way too much information in one place, I briefly referred to it. One of the challenges of getting the numbers compared to cognitively intact populations, of course, is that our measure it depends on however you measure it. And we get wide variability in our studies depending on what measure is used and what setting it's conducted in. But what we see is that it does mirror at least the levels of pain in the general population of older adults.
That makes sense. I did hear that, but I just didn't know if there was any ballpark figure. So I have a quick second question to follow up. I thought the facial expression of pain assessment was quite interesting, and I'm assuming that you don't mean using the 10 smiley face figure. You mean like the actual on a person's face. So what like do you mean like they are more expressive in their face in terms of pain, or what did you mean by that a little bit? I that caught my attention a little bit.
Yeah, basically, yes, we don't use the Long Baker Faces Pain Scale, right? Because that actually requires participation, and things like that. Um, but what we are talking about is so the research that kind of backs that up is that Miriam Kuhns and Stefan Lotenbacher, I believe, were the two people who did some of the original research. And they have this facial action coding system. I think it's 36 different things that they code, but don't quote me on the number of things that they code. They can actually look at changes in facial action, and when you compare it across a lot of people, we see more expressiveness, more activity in relation to pain. Whereas then we might inhibit our facial response a lot of times as part of our response to pain. You'll see some of that less. But again, I preach the same old story that the family caregiver or the prolonged caregiver, whoever that is, knows best because invariably in interviews with caregivers of all kinds, they come back to talking to me about facial expressions of pain unprompted. I don't even prompt them, and they start telling me about how useful that is and how they use these facial expressions. And you don't hear about that in the general population when we talk about pain assessment as much. So we know it's a real key thing. And one of the challenges is that I can't tell family caregivers, well, it's definitely be this, and this movement. There is some individuality to it, and that's where that long relationship that you have with the person of just knowing the person, of seeing them every day and being able to observe change over time, really has a value.
That's fascinating. I'm gonna see if there's anybody else. Bianca, you always have a
Yes,
question.
yes. I mean, Jeffrey, thank you for such a thoughtful presentation. I mean, gosh, I think even just how you opened it up to talk about your own experiences of your father wondering, whether, his family member was in pain and just you realize how difficult. You can't really know what people are feeling if they can't communicate it. So I appreciate this conversation about some other markers of pain that maybe we sometimes don't consider that could be beneficial to not just people with dementia, but anybody to identify what those markers of pain are. I heard you at the end, though, make a comment that you didn't feel like it was appropriate to kind of connect it to workforce, but you are talking directly about a workforce that really matters, which are the caregivers. And I think, especially in the ward network, we do want to kind of really highlight the fact that the family caregivers are very much part of the health workforce that we care about, paid or unpaid. I'm curious when you talk about the network that they may have, could you just speak a little bit more to kind of what some of those relationships are and how like the medical system kind of is a partner or are they considered a partner or part of that network that you have in mind? Because I think for the medical side, they don't think of family caregivers probably enough as part of that way of thinking. But how do you think about it from the caregiver side? Are you encouraging them to also think about the medical side as being part of their network?
Yes, and it's multi-layered, and the analysis is coming very soon. Because I'm almost done with all the data, but and there's actually another caregiving network study, a very large one that's going to be tracking going on that is some other individuals. First of all, the thinking that I didn't belong in a workforce discussion was me bringing my own bias, and then I thought, wait, no. Family
You definitely
caregivers are like
belong.
a huge bulk of the workforce. We belong here. So it was me bringing
Absolutely.
my own bias, and it opened up new avenues of thought for me that I was really excited about. So it gave me an opportunity to think and grow. In terms of family caregiver networks, I look at it, in a number of different ways. Really, primarily conceptualized it as there tends to be kind of a hub caregiver. There tends to be that point person. But different factors related to proximity, the skill of an additional person will affect how they interact with the care recipient and kind of that hub caregiver. Um, and and so it will change and shift. Certainly, they frequently do talk about the primary care provider in terms of their caregiving network, about where they seek information, and as an important person for which there might be challenges with communication or whatnot. And so that's key. They also, as I hear the stories, these networks shift and evolve. For example, as caregiving fatigue sets in on, for example, a hub person who maybe was being more of a solo caregiver at one point, and then maybe siblings find models to split up care, but also to share information. I'm really interested in how they share information, um, and about how they inform each other about things. In my case, because I want to know how they manage pain, but it really applies to a lot of symptom management. And so we also hear about friends networks, either maybe cognitively intact friends of the care recipient step in. That's why my definition of family caregivers also includes close friends, neighbors. A lot of times, an older adult who's living alone when they're experiencing early symptoms, a neighbor is someone who frequently steps up and becomes part of the caregiving network. Um, so it shifts and change. I think as proximity, available skills, and available time are really what affect that. But I'm interested in knowing how they work and communicate, and I think it's a burgeoning area of caregiving research.
Definitely. And actually, it makes me even think about, I mean, I know you're focused on the home care setting, but I was just thinking even in the nursing home setting where family members come and visit and they may be giving, maybe more attuned to folks there and that they really become potentially another set of eyes and ears.
Mhm.
Um, but thank you. Very interesting. I see a question that came in through the Q&A, Jen.
Oh, yeah. So we have a question from the audience. Are there differences you see between early onset compared to later onset dementia?
Um, Yes, I'm trying to determine and what types of difference are being asked about, but I can speak about a couple. In terms of pain, certainly we see we're all familiar with the progression of different dementia types. And we know that ability to self-report decreases, reliably answering certain types of questions can. But we also see this in the caregiving networks, and I think it's been coming out in some of the interviews that I've been doing. Is again, like I said, early on, um, you may have less intensive needs, and so one caregiver may step up, but then the caregiving network becomes ideally more complex and more supportive as the needs increase. And that does tend to be the pattern. Um, but okay, you're asking about both. Um, uh, that does tend to be the pattern is that, um, especially if you remain in the community setting, is that um, the stressors increase, and so ideally, at least, the network would increase, and so you would identify people who can fulfill different roles to kind of spread the burden of caregiving. But if you notice, like if you look at the statistics, the number of caregivers exceeds the number of people living with dementia. And so we know that it takes multiple people to provide care for someone, safe care. But yes, the pain processing changes, and so you will see changes in behavior, which again is one of the reasons why having consistency in someone who observes um, is very valuable. You'll see some progression in the behavioral changes as well as the ability for the person to contribute to their pain assessment.
On that real quickly, in terms of treatment though, because we talked a lot about dementia, like patients with dementia expressing pain differently, or maybe there's even like a modulation. But in terms of treatment of pain, like are there any differences, or is it typically you treat pain, treat the cause and such? So like the treatment would be the similar, I'm assuming.
Treatments are pretty similar. Again, you want obviously you want to determine an underlying cause. For example, pain medications are not going to treat the underlying cause if your pain is a urinary tract infection, which is very common in our older adults and especially those with dementia. Um, what I always say too is that people experience have complex pain in the sense that we have different causes, we have different chronic pain experiences, different pain is a multi-dimensional phenomenon that has, emotional, cognitive, sensory, as well as different impacts, such as pain interference in your daily life and everything like that. And so one reason I think it's so important to help family caregivers develop effective pain communication strategies with healthcare providers and with the healthcare provider as part of their network is because you really need an individualized care plan for pain. Um, I have a whole nother talk. It's like an hour. We talk about assessing and managing pain for family caregivers. And so it goes into much more depth. At the end of the day, I don't actually come down on telling people this is when you give this medication and this is when you give this medication. Because again, are we treating musculoskeletal pain? Um, are we dealing with other complexities such as impaired renal or hepatic function that affect choices of medications? A lot of people, you know, tons of our pain medications are on the beers list, making them, advised not to use or to use with caution in older adults. And then also I say it's sometimes the best approach is usually a stepwise approach. I always get asked eventually when are opioids appropriate? And the answer is that we usually use a stepwise approach of managing pain. But again, it needs to be individualized to the person and with someone who can appropriately monitor therapy.
Perfect. Thank you so much. We're right at 12:59. I feel like I learned a lot. And if anybody has any questions further, I'm sure you are happy to be contacted about this topic. So I'm gonna hand it back to you, Bianca.
Well, thank you so much, Jen, for emceeing this event, and Jeffrey for your wonderful presentation. Thank you to everyone for attending today. Again, this has been recorded and will be available online. So please let your colleagues know about these recorded sessions. Thank you so much. Have a great day. Bye, everybody.